Any patient who is a good candidate for a total knee replacement, that is chronic debilitating pain affecting anyone's daily routine activities, and he or she probably has exhausted most of the conservative lines of management, is a good candidate for total knee replacement. He or she as such belongs to a good candidate.
As you can see on the screen, this is how UI of the MISSO panels looks like. So this is the patient we are going to operate today. So this is a 60 years male patient. You can see the CT slice thickness, CT slice space, dimension, everything. So the CT protocol is actually good. We are doing 1 mm of recon in the CT. Once this is done, we go to reconstruction of the bone. So you can see the masking over here. The masking has been completely good. So if the masking goes, the final output of the saw bone, the final output of the bone looks good. So you can see here AI-based segmentation. What we have did in MISSO planning laptop is we have incorporated machine learning and AI-based planning. Once I click this button, AI-based planning, it will automatically reconstruct the 3D model in just 2 minutes. So this is how we upcome with other robots. So this is the benefit of our planner than other robots. We'll go to femur axis. As you can see, in all the planes, coronal, axial and sagittal plane, we set mechanical axis over here. As you can see, the point is already on the bone. So with the help of the machine learning, the software is so smart that he knows where to take the point. As you can see, the head center is completely as per the mechanical axis. If I change any landmark, it will change in all the planes. So I'll just set it up as it was exactly there on the bone. I'll move to condylar center. As you can see, I'm marking my condylar center space here. medial epicondyle, we have to take point on sulcus. Lateral epicondyle. So you can again see the accuracy of system. It knows where to take the point with the help of the machine learning. On the epicondyle, the software has already set the plan on lateral eminent part. You can see the plan here. Medial posterior condyle, the point is again proper. I'll just refine it a little bit. Lateral posterior condyle, I'll just refine it different bit. Now you can see the TA with respect to PCA is 1 degree axial rotation. So I can change my axial rotation from here. If I want to increase the rotation, I'll just simply click on medial epicondyle. I can change my rotation. So I'm setting my rotation to 0 degrees of axial rotation. You're basically setting the mechanical axis. Ideally, setting a mechanical axis, everything should be 0. So as you can see, depending on my axial landmarks, the system has given me perfect size. So first I'll check the sagittal view. So as you can see, this medial side looks good, lateral side. So as you can see, the AP is looking perfect. So size D is perfect for this patient. I'm moving, I'll just check the axial view. You can see the groove, how the patella groove is matching. So this is how the magic of MISSO planner works. Just setting the axial point, system has given me perfect implant size. As you can see, flexion is 0. If I want, I can change it to 1 degree, 2 degree, to reduce the posterior cuts. So posterior cuts for size D implant is 8.5. So I can simply, change give it little bit flexion and I can settle the posterolateral gap to 8.5. I can upsize and downsize femur. So these are basically joysticks. I can play with it and I can set my implant. I'll go to internal external rotation screen. I can rotate my implant, external rotated or internal rotated, but we are setting the mechanical axis, so I'll keep it 0. And we can change the planning in gap check, intra-op gap check. Once this is done, we'll show this plan to surgeon and surgeon will give the approval. As you can see, once surgeon will approve the plan, then only then we can export the plan, and once I export the plan, we can execute robot doing surgery. Thank you.
Good day everyone. So we are going to do surgery on a patient, 61-year-old gentleman with chronic left knee pain and deformity since 6 months, affecting his daily routine activities. So this patient has got a 14 degrees of varus deformity on his left knee. When I check the overall anatomical phenotype, he has got 14 degree varus, of which his MLDFA is 90 degree. That means he has got no deformities on the femoral side. And when I check the medial proximal tibial angle, it is 85. That means there is a mild proximal tibial varus. But that indicates that most of his varus is intra-articular and because of some soft tissue contractures as well. So I always follow the CPAC classification. So this patient's knee belong to the coronal plane alignment knee classification of type 1. That means his phenotype is varus. So when I calculate the arithmetic varus, that means his MPTA minus LDFA is -5. That means it is a varus knee. And when I calculate the arithmetic mean of MPTA plus LDFA, it is 175. That clearly indicates that his joint line obliquity is in a distal direction. That means this particular knee's anatomical phenotype is varus and the joint line obliquity is distal. So it's an apex distal varus knee. That means CPAC type 1. So let us try to put the his knee back to a CPAC type 1 box. So I personally believe that somebody who is having a CPAC type 1, like we follow in mechanical alignment, we shouldn't put the knee back into the box of CPAC 5. As far as possible, if his phenotype belongs to varus, if his joint line obliquity belongs to apex distal, let us try to give him back the original phenotype and joint line obliquity. So shall we start? We are moving to the robotic steps right now. So the first thing is placing the tibial and femoral markers. So as I explained earlier, the rule is 2 palm breadth below the articular surface. That's it. Okay, 2 points. You feel for the crest of the tibia. Okay, 1.5 to 1 centimeter andromedially down to on the crest of the tibia. Make a stab incision. So just 2 stab incision. Place the jig. Feel for the anteromedial shin. Okay. Yeah. Place the jig. Yeah. So check whether you are at the right position. These pins are placed little anteromedial. Feel for the crest of the tibia and make a unilateral and just go and touch the far cortex. Never make it a bicortical thing unless you are dealing with a grossly osteoporotic bone. Otherwise, a unicortical pin is good enough to hold without producing much micro motion. So I'm done with the near cortex, just going and feeling the far cortex but not piercing it, thereby avoiding much of the stresses on the far cortex. Now going to place the femoral pins. Again, the landmarks are very simple. If you are going a medial parapatellar approach or if you are a subvascular surgeon, it doesn't make a big difference for any approach surgeons. So this is going to be like 15 to 20 degree tilted from the or from parallel to the ground. So the key point of why you should be placing the femoral pin at this level is you are actually facilitating the ergonomic workflow of your robotic arm. It should not come and hitch the sensors placed on the femoral tracker. Previously we all started with the shaft pins, but after trial with multiple cadaveric this thing, within the incision trackers are more comfortable than the shaft pins. So we have this DMIO stand and a posterior distractor to keep the joint distracted so that all our anatomical landmarks are well registered for our micro-millimeter precision planning. So I'm going to enter into the next step, which is the femur registration. Go. So we'll be registering 9 points in the distal femur. Those are the initial 9 important landmarks which we need to register on the distal femur. Yes, medial point, lateral, distal, anterior, yes, anterior medial, anterior lateral, posteromedial and posterolateral. RMS is getting better every time I repeat now. It's better. Yeah. So the middle femoral condyle, yes, 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 yes. Now on the trochlea, yes. Yes, yes. So that's our final RMSE of 1.1. Good to go? Yeah. So that means we are within within 1.1 millimeter of all the points that have been matched to the preoperative CT evaluation of the patient. Yes, please. Yes. 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 Proximal medial, yes. Proximal lateral. And the proximal point between the interspinous area, yes. So now the 7 points on the proximal tibia with the initial RMSE 11.3, that's good to go. Now on the medial tibial condyle, yes, 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 yes. Now the interspinous area on the medial tibial spine now, yes. 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 So all the 10 points marked now. And let's see the final RMSE. It's very great. It's 0.7. So again, merging points on the proximal tibia. First on the medial side. It's 3.3. Yep. Anterior. Yes, can you zoom it little? Yeah, it's 1.7. Fine. Go ahead. Go ahead. Yeah. So we're done with the registration. 80 points in the distal femur, 80 points in the proximal tibia. And now going to the next step, that's our most important part of this surgery. It's a virtual gap balancing. Okay, as per the pre-operative planning, we have a size D femur and have approximately made the cuts from the distal medial, distal lateral, as you see in the monitor. Okay, so this is full extension. In full extension, you can see that flexion extension box over there that's showing a -3. That means compensating for the anteversion at the hip, I'm getting almost a 7. That means almost 10 degrees of hyperextension for this knee. This is after my total meniscectomy. I can take away 5 mm compensating for my meniscectomy. So this knee is right now in 5 degrees of hyperextension. What I want is compensating for the anteversion at the hip. It should be somewhere around 5 degrees. This is what I want. The original varus is, as I mentioned before, it's almost 14 degree varus. But after my preliminary release, just the anteromedial release, the maximum varus which is coming is around 10 degree, which is almost fully correctable to neutral. You can see that the left bottom screen, the varus valgus is showing 0. Okay, at this position, that means when I'm getting a reasonable full correction of deformity of this knee, I'm having a varus 0, flexion extension of 3 to 4 degree. I'll keep a relatively loose knee for him. So at this stage, my medial and lateral space are almost equal. That is 9, 9. So that shows that my preoperative planning was so good. So that is medial 9, lateral 9. I don't have a space issue in extension. So let me come to my flexion at around 89, 90 degree. You can see the flexion is tight. A medial space 2, lateral space of 6. So what is there in my clinical distraction? Okay, of the patella where I can distract this thing. When I distract, so my space comes to lateral side 6, medial 9. So it is not, the flexion space is tight, medial extension space is loose. Now my target is to make my flexion space, extension space, medial and lateral all square, right? So my target is to make flexion space also equals my extension space, which is 9. Okay, so before going into making corrections with respect to my component positioning in femur and tibia, I would like to see what is the stretchability. So I'll use 2 distractors. on the medial and lateral side. See, how much is my flexion space stretchable? See, previously it was 2 and 6. Now, the basic stretchability of this knee, the soft tissue stretchability of this knee is 5 and 9. So that means my lateral space is good enough, it is stretchable, and medial space is little tight. So I want to open up my medial side. That's what my target is right now. Before going ahead, I would like to see the stretchability of my extension space as well. So that was 9 and 9 equally, but my extension space is stretchable up to 11 and 13. Please capture. Yeah. So once again, that is my maximum space which I can expect if I make the cuts as per my preoperative plan. So this is, I'm just trying to stretch again and see whether I should make some finer corrections my flexion space as well. So laterally stretchable up to 10, medial is 6. Please capture. Yeah. So that's my base values on which I'm going to work now, so that I will square my extension and flexion spaces equally. So just go to femur implant, femur rotate, external rotation 1, one more. So see, my flexion medial space is getting opened up as well as my lateral space is getting closed. So it's 7 and 9. Yeah, that's good. Now I want to cut down on my extensions because basically I am getting a hyperextension as well. So I'm going to go less on my distal femoral cut. Go to femur implant, distal 1 mm down. Okay. 10 and 12. Yeah, distal 1 more mm down. So 10 and 11. That's good. So my lateral space is getting balanced. Medial is reasonably opening up. So now go to femur again. So as per my preoperative planning with respect to my scanogram, I have a LDFA of 90 degree. That means this patient doesn't have any bony issue with respect to this femur, and there is a proximal tibia vara. We are going to replicate the same thing. So I'm going to give some amount of varus in the proximal tibia. Okay, so go to tibia implant, tibia rotate, varus 1. So see now the extension space is totally balanced to 10 and 10. That's the maximum stretchable value. But even at this stage, my flexion space is too tight. It's only 7 and 8. I don't want to struggle with my flexion space. The patient will not have a good postoperative range of motion if I accept this. So I'm going to increase my flexion space. Go to femur again. Femur rotate, extension 1. So I'm going to, so I've kept the femoral component in flexion preoperatively. I'm going to extend the femoral component so that I will go down on my extension space and I'll go loose on my flexion space. So I'll achieve two things when I extend the component. I will relax my flexion space as well as I'll tighten my extension space. That is exactly what we want in this particular case because we have a loose extension space and a tight flexion space. So now see, it is 9 and 10 in the extension and 7 and 9. So it's getting closer and closer. Now, so we have given only 1 degree of varus. That means you are going to end up with an HK of 179. My target is to create a HK of 177, which will create a good functional alignment for this particular patient. So give 1 more degrees of varus, that will open up my medial space again. Okay, go to tibia, 1 degree varus, tibia rotate and 1 degree varus. See that? So it's 9 and 9, 8 and 8 now. Okay, I'm almost squaring now. So its extension is little loose, flexion is little tight. I would like to square and go before I make any further cuts. Okay, close. Now go to femur implant again. No, close. Femur rotate. Reduce that flexion again. Go to extension 1. Okay, so it's 9, 9, 8 and 9. I have almost completely squared. So we had a big disparity between our extension space and flexion space in this patient. Now we have squared completely. It's 9, 9, 8 and 9. You can see the square now. So without any further release, you have squared both the medial and lateral space, both the flexion and extension space. So this is the beauty, that we are slowly tweaking the femoral component positioning, tibial component positioning in such a way that we are creating equal flexion extension, a perfect rectangle that you are going to recreate. Close. So you're almost done. And finally checking again, you're making a, at this stage, when I've made all these changes, I'm checking again how much bone cuts I'm making. So in flexion, we are taking a 10.6 cut, 8.4 on the lateral side, and in extension, we are cutting very minimal. See, that make sure that your basics are absolutely right, because this knee had some hyperextension, for which we are making less cut in the distal femur. Flexion was very tight. We are taking more cuts in the distal posterior condyle. So 9, 9, 9 is well squared. So I think we'll go with 9 so that we have a very minimum poly inside. Okay, go next step. I hope it's clear. And all the sensors are being in the work field. We'll proceed with the robotic bone cutting. So all the sensors are being detected, and the tibial markers, the femoral markers, the robotic markers, all the sensors are in the front view, top view, well accessed, and the bone angles are also showing yellow in color. That means you are good to go. So now the robo is in motion. Robo is going to make the distal femoral cut first. As per the plan, it's going to cut 5.4 mm from the distal medial side and 5.8 mm from the distal lateral side. That's going to give us the desired extension space.
Check. It's almost a perfect square.
We in India have developed one of the best automatic robotic knee system. How MISSO scores little over other robotic system? The main key point is that it's very slim and sleek. It's not going to be an elephant in your operation theatre. The first point, and the brilliant engineers have incorporated one of the smoothest motor, which gives you the ultimate feel of precision. And the third point, they have created such a useful user interface wherein you have absolute control over each and every minute points with respect to the initial registration, the femur registration, tibia registration, and the virtual gap balance. You can play around like you do on a video game, that how well you can realign and reposition your component by making fine tweaking here and there with respect to flexion extension, changing the varus valgus, changing the internal external rotation, the overall HK axis, thereby creating or recreating a natural anatomy, natural biomechanics, recreating a perfect posterior condylar offset. Every small, minute, precise points is well recreated, and it's very user friendly for anyone, even for a beginner.
MISSO exclusively coming down with orthopedics can really add a lot of value into their divisional practice, their portfolio, and they can really leverage out things into orthopedics. I see this as a big opportunity. Mostly corporates from tier 1, tier 2, tier 3 cities can adopt where there was a problem of the costing, where there was a problem of utility, training, because we believe in providing a real-time solution to all our corporate hospitals.
We started this journey with a possibility of creating something unique for the industry. We spent time, energy, resources, and our talent to identify things that will make a difference. Today, I'm happy that we as a group have been able to achieve 4 successful cases in the last 24 hours to make sure that we demonstrate to you what the versatility of the system is. We have taken feedback from multiple doctors, multiple of our internal staff members, whatever is available outside, done extensive research and identified things that makes patient outcome better. We will spend the coming decade taking this technology to every part of the country and then to the global outreach. This journey would not have been complete without our team, without the support of our management, without my family. I would like to personally thank, on behalf of everyone, to all our doctors who took part in this, all of our team members who made contributions to this, to our R&D and manufacturing team to get this thing done in time and to perfection. I want to thank who believes in us in adopting this technology into their ecosystem to help their patients. It is my humble request to my team to continue this effort, to all of you to adopt us with open arms and give us an opportunity into your hospitals. For us, as we look into the future, MISSO, I promise to you, will be future forward.